Hi, everyone. Hope you're doing good. This presentation is going to be a discussion on cervicogenic headache. This was kind of an extension of a letter to the editor, Dr. DeVay, and I wrote back in 2020 to the PM&R Journal. And we felt like this would be a good topic to discuss on Care Week. So we have no disclosures for this presentation. And really the objectives are going to be to define exactly what cervicogenic headache is. It's a tricky diagnosis and it's easy to get it wrong, but we also want to focus on what it is not, because it was a lack of clear definition, which was what prompted us to do this review in the first place. We're also going to then compare and contrast the different diagnostic criteria for cervicogenic headache. There's a couple of different groups that have different opinions on how to diagnose this disorder. And then we'll understand how procedures can be used to diagnose it and what we can do in clinics to help these patients. So cervicogenic headache is a tough diagnosis to make, and it's more difficult than what we would expect. Most people would think of it as a headache and neck pain, and it's kind of thrown into the cervicogenic camp, but that's not really the case here. It's relevant to us because at RHI and IU, Dr. DeVay does see cervicogenic headache, and so it's important that we diagnose it properly. How we treat cervicogenic headache is different than how we would treat, say, a migraine headache. And so we really need to make sure we have the proper diagnosis before we set patients on specific treatment plans. So in 2020, there was a paper published in the PM&R Journal called Clinical Perspectives on Headache After Traumatic Brain Injury. Essentially, this article was trying to examine the relationship of headache prevalence following a traumatic brain injury. And they were looking at the different types of headaches there. They had different categories of headaches that we're looking at, one of them being cervicogenic headache, which they defined as, quote, unilateral neck pain, and the criteria was not met for migraine, probable migraine, or tension type headache. Essentially, they were saying that if a patient reported neck pain and a headache, and they didn't fall into the migraine or tension type headache camps, then this is cervicogenic. And we really felt like this is an oversimplification. This is a complicated disorder to diagnose in patients. And this just felt like a little too simple. I mean, you can have unilateral neck pain, but it's more complicated than that. So there are two schools of thought when it comes to diagnosing it. There's the Cervicogenic Headache International Study Group, and there's the International Classification of Headache Disorders, 3rd edition. This first one, the CHISG, they have 7 clinical criteria that they use, but the 2 I have here that are bolded are the 2 that are absolutely essential for making a diagnosis. So having that unilateral headache that just stays on one side, and the pain starting in your neck and then radiating up to the back of your head, the side, the front. You have to have those 2 things in this group in order to have a cervicogenic headache diagnosis. The other clinical criteria would be things such as the pain is worse when you move your head, or a nerve block makes it better. In comparison, the International Classification of Headache Disorders, they focus more on the actual target, a pain generator, so to speak, that they think is causing the pain. And this could be either something you find on physical exam or a lesion that you see on imaging. So both of these camps would recommend a diagnostic blockade. So if your patient comes in and they seem to fulfill one of these 2 different sort of criteria camps, then we would still proceed with a diagnostic block to see if that makes things better. And if it does make things better, that would point towards more of a cervicogenic origin. Typically, our first target is going to be the 3rd occipital nerve. And the reason being is that I believe the literature says in about 70 to 80% of cases, the 3rd occipital nerve is the most common culprit for this disorder. It crosses the C2, C3 joints, and it provides basically sensation to kind of the inner back of the head. Now, how do you know that it's a successful block? Basically, 2 ways you could tell is, first off, you should see some fairly quick improvement, probably the same day as the block, since we typically use a bupivacaine. They should see about 80% pain relief. And also they should have better range of motion of their neck. They should be able to do things with their head and neck that they couldn't previously do because it was painful. Now, if this fails, but we still really have a strong suspicion of a cervicogenic headache, then we would try targeting the atlantoaxial joints and numbing it there. So really, in conclusion, the paper that we had read, their diagnosis, we felt really wasn't specific enough to accurately make a diagnosis of cervicogenic headache. And so then that led us to wonder, well, the numbers that they're reporting, are these really accurate? We wrote a letter to the editor and submitted it. And for some reason, they actually didn't publish it. They didn't give us any feedback as to why, but we felt it was a good letter, but for some reason they didn't feel like publishing it. But I felt like it was good to still review the diagnostic criteria here. And it's important to keep this in mind when we evaluate our TBI patients at RHI who come in with headaches as well. I want to thank Dr. DeVay again for bringing this article to our attention and also providing assistance in drafting the letter to the editor in the first place. That's the end of this, and we'll open this up for questions if there are any. Thank you for listening.